I'll just try and share my slides. Okay, hopefully everyone can see my slide. I suspect you can't see me, but I'm sure that's me. I wonder if it's just taking a minute or whether I should shut down. My camera is still on, I've noticed, which I think should actually switch off when the slide shares. So I'll just go back. Another try. Oh, hang on. I know what I've done wrong. Sorry. I'm being silly.
You can see the slides now.
Okay, terrific. Thanks very much. So thanks, Sam. Thanks also to the AACB and the IFCC for this opportunity to speak tonight on one of my very favourite topics. Oh, I'm not moving forward. Sorry, the slide's not advancing. Should I start again? Stop sharing.
Maybe let Esmeralda do it from the office.
Yeah, okay, I might have to if it's not working.
So you have to stop sharing.
Sorry about that.
Okay. If you close your PowerPoint,
I've closed my PowerPoint. Is Esmeralda able to share?
Yeah, IFCC, we should do it now. Yep.
Okay. So we're right now? Great, thanks, and I'm sorry about that. As I said, thanks very much for the opportunity to speak tonight on one of my favourite things, vitamin D. Next slide, please. I'm dedicating this presentation to my late husband, Professor Howard Morris, who I'm sure many of you know is an internationally recognised expert in vitamin D, particularly in the context of bone health. And it is he who inspired my passionate interest in this subject. Next slide. The term vitamin D refers to both cholecalciferol or vitamin D3, which is formed by the action of sunlight on skin, as well as ergocalciferol, vitamin D2, which is formed by UV irradiation of the plant steroid ergosterol. The 25-hydroxylated form of vitamin D is the major circulating form, and the 125-dihydroxylated form is the biologically active form. I think it's important for us all to know, though, and to remember, that vitamin D is actually not a vitamin. We've known for a very long time now that vitamin D was recognised as a member of the steroid hormone family. Next slide, please. This is just a very simplified schematic of vitamin D metabolism, whereby, all being well, UVB irradiation from 290 to 320 nanometres hits the skin and converts 7-dehydrocholesterol to pre-vitamin D3, which then, by terms of body heat, is isomerised into vitamin D3. That sunshine-formed vitamin D3 can then, as can dietary D3 or D2, be transported by the vitamin D binding protein to the liver, where the 2R1 enzyme catalyses the first hydroxylation step to 25-hydroxyvitamin D. It's then transported, or they all can be transported to the kidney, where the 1-alpha hydroxylase, or CYP27B1 enzyme, catalyses that second hydroxylation step to 125 dihydroxyvitamin D, which is the active form, and it exerts its activity by binding to vitamin D receptors and then exerting influence with the vitamin D responsive elements within cells. I think it's important to know that the vitamin D receptor has been found on the surface of almost every type of cell. Next slide, please. Moving to metabolic bone disease, which includes osteoporosis with its consequent fractures and somewhat less common conditions such as rickets in children and osteomalacia in adults, as well as the hyperparathyroidism in its various forms that Sam's already addressed. I think there is confusion with some people, at least, between osteoporosis and osteomalacia, and people seem to merge them into one, but they're really quite different conditions. And osteoporosis, the overall bone mass is decreased, but the ratio of bone mineral to bone matrix is normal. Osteoporosis is caused by some kind of combination of low peak bone mass, impaired bone formation, and increased bone resorption. And typically this is a clinically silent disease until a fracture occurs. By contrast, osteomalacia, which literally means soft bone, has a low bone mineral to bone matrix ratio, and typically this condition is due to severe vitamin D deficiency. And by contrast to the clinically silent osteoporosis, osteomalacia has hallmarks of a lot of bone pain and muscle weakness. Next slide, please. So osteoporosis is the most common metabolic bone disease, and it's a major health issue globally. The World Health Organization estimates that as many as 23% of women and 12% of men globally have osteoporosis. In Europe in 2010, 3.7 million fractures occurred and cost the economy an estimated 37 billion euros. And the situation is not predicted to get better, such that by 2025, it's predicted that there will be 4.5 million osteoporotic fractures and obviously attendant increase in cost. In the US, it is estimated that there'll be 3 million osteoporotic fractures annually by 2025, estimated to cost the US economy over $25 billion US. In Australia, our figures look a little more modest. In 2020, we had 173,000 fractures at a cost of over 3 billion Australian dollars. But when you think about 173,000 fractures, that's 1 every 3 minutes, roughly. So this is obviously very prevalent and incurs huge economic burden, but it also incurs significant personal burden. So almost 25% of those who sustain a hip fracture will die within 12 months. 80%, up to 80% might die within 5 years, and almost 50% of people never regain full functionality. And you might think of all these things as being prevalent in only very old people, but in fact the mortality data holds true for younger generations. Next slide, please. So the question, move on, thank you. Can anything be done? Yes, I think emphatically yes. In fact, it may even be largely preventable by undertaking these measures. So we must have adequate dietary calcium. It's not as easy as you might think. I read an article very recently that suggested that almost half the world's population has inadequate access to dietary calcium. And we need a lot of calcium. So in Australia, our recommended dietary intake is 1,000 milligrams for adults 19 to 50 years of age, increasing to 1,300 milligrams for women more than 50 or men more than 70. Now, as well as dietary calcium, you need optimal vitamin D status, more about that later. And as well, you should undertake weight-bearing exercise, and as for so many other health outcomes, you should not smoke. Next slide. So what is the target for 25D? These are decided by desired health outcomes, certainly not by creating a traditional type reference range. And the 25D level required to prevent osteomalacia is actually quite low. It's around 20 nanomoles per litre or 8 nanograms per mil. You need higher levels, as Hans has already shown, to prevent secondary hyperparathyroidism. And the American Geriatric Society state that in order to prevent osteoporosis, you need 75 nanomoles per litre, which is 30 nanograms per mil. In this, the International Osteoporosis Foundation agrees with them, 75 nanomoles per litre, while the National Academy of Medicine offers a suggested range of between 50 to 100 nanomoles per litre, and makes the observation that there is currently insufficient evidence to determine the safe upper limit, but says that there is concern for levels greater than 125 nanomoles per litre or 50 nanograms per mil. Thank you. Next slide. So I mentioned calcium deprivation is pretty common. What about the prevalence of vitamin D deficiency? This is a table that identifies a number of prevalence studies from countries around the world. You see it's rather busy, but the extreme left is a very insufficient level of around 22 nanomoles per litre, and the figures there are not strikingly high for most. But if you then look to the column of 20 nanograms per mil, which is 50 nanomoles per litre in the middle there, you can see that there's no single digits and that a number of countries are over 40, 50, even 60% prevalence. And if you move to the far right column, which is the bone recommendation for more than 75 nanomoles per litre, the prevalence is huge. Now, this data is perhaps a little old. Has it improved? Next slide. Sadly, the answer to that is no. And I've created a table here of some more recent studies, and you can see still that at a significant deficiency of less than 30, it still exists. And at the 50 nanomolar cut point, again, the prevalence remains very high for some countries. Thank you. Next. So we think of vitamin D actions, principal endocrine actions, as being those to regulate plasma calcium homeostasis. And it does this by increasing intestinal calcium absorption, as well as reducing renal tubular loss of calcium, and when needed, extracting calcium fairly efficiently from the bone. And these endocrine actions of vitamin D can resolve osteomalacia, and we know, as I've said, that the level for that is actually quite low. It's 20 nanomoles per litre or 8 nanograms per mil. Next slide. Why do I say this? Well, this is evidence from Howard's lab. This is a rat dietary model, and if you just focus on the picture of the femur there, you can see that this is very, very poor quality bone with markedly reduced cortices and a central bone area that is very highly tubercularised. And this occurs at a level of 25D of around 11 nanomoles per litre. Next. Thank you. You can see now just by moving the 25D level to around 20 nanomoles per litre, so this is now a switch of around 4 to 8 nanograms per mil, the osteomalacia has resolved. We now have strong cortices and the central tuberculisation has largely resolved. Even so, this is not terrific bone. This is still osteopenic bone, which is the forerunner to osteoporosis. Next slide. So we can't chop up human femurs very readily, so we can look at surrogates though, such as the active hormone 125 vitamin D levels here in the panel on the left, and intestinal calcium absorption in the panel on the right. Again, this is work from Howard's lab, and you can see that in these, they're all vitamin D deficient. But it's not until the 25D level gets below around 20 nanomoles per litre that you start to get significant decline in active vitamin D and intestinal calcium absorption. Next slide. As Hans has already shown, you get a significant increase in parathyroid hormone at somewhat higher levels than you need to correct osteomalacia. So anything under around the kind of 60 level, 50, it starts to precipitously increase PTH. Next slide. Next slide, sorry. This is just a cartoon showing the process of remodelling. I'm not proposing to go through this. The only point I wanted to make from this slide is that all the different cell types involved in this remodelling process, from the bone and the marrow cells, can independently synthesise their own 125D to elicit biological activities. Next slide. And so these are, by definition, autocrine and paracrine activities rather than endocrine. And these actions can either enhance mobilisation of calcium or retention of calcium in bone by stimulating bone resorption, inhibiting bone cell proliferation, and stimulating bone cell maturation. Next slide. So we've actually had randomised control level evidence for a very long time now that supplementing with vitamin D and calcium can prevent hip fractures in elderly women. These plots are from the seminal work done by Chapuis and colleagues in French nursing home study, the original one published in 1992. And you can see both for these elderly women were supplemented with 1,200 milligrams of calcium and 800 international units of vitamin D daily for 3 years. You see in these plots, which cover the 18-month time period, that both for hip fractures and other non-vertebral fractures, there's an almost continuous decline in the cumulative probability of fracture shown in the closed circles. And Chapuis and colleagues repeated this study 10 years later and got much the same result. Next slide, please. Sadly, a lot of nutrient studies are actually very badly done, and I'd urge everybody to be very careful about how they interpret studies done in nutrients. And so I am selective in things that I'm showing, studies that have been done well. This is a meta-regression analysis done by Bischoff-Ferrari's group, where the serum 25D in randomised controlled trials is plotted against fracture risk. And you can see for increase in 25D from less than 30 to more than 60, you have a progressive decline in the hazards ratio for both hip and, again, non-vertebral fractures. Next slide, please. This is a meta-analysis of data from clinical trials that concludes, you can see the forest plot shows the significance of low vitamin D in these patients, and the conclusion of this meta-analysis is that the risk of hip fracture is reduced an average of 26% with vitamin D and calcium supplementation in postmenopausal women. So vitamin D important, but also calcium, and most trials show that vitamin D alone does not have the desired effect. Next slide. What about effects on bone mineral density? These are data from N. Haynes, and you can see 3 groups of histograms there. Each group represents a quartile, increasing quartile of dietary calcium, and the 3 groups represent increasing vitamin D concentrations from less than 50 to 74, and the proposed more than 75 nanomoles per litre. And you can see effectively there's a continuous increase in bone mineral density across these groups. Next slide. Just a word about falls, because part of the prevalence of fracture is contributed to by falling over a lot. And there has been a meta-analysis done some time ago now, but showed that there's a 15% reduction in falls in the elderly who are supplemented, again, both with vitamin D and calcium. And very important, it's observed that these effects are greatest in those who are vitamin D deficient at baseline. There's no point in having more if you've already got enough. And certainly it's also shown that typically daily or perhaps weekly supplementation is best, and evidence for giving too much all at once has been very well demonstrated in this study, which gave 500,000 units of vitamin D in a single dose. They had to stop the study early because both falls and fractures were increasing. So daily or perhaps weekly better. And I'll finish this section by just sharing with you the American Geriatric Society guideline statement that says clinicians are strongly advised to recommend vitamin D supplementation of at least 1,000 international units per day, as well as calcium supplements to community dwelling older adults to reduce falls and fractures. Next slide. Finally, just a quick word about hyperparathyroidism, which Hans has already described. And as he described, it's concurrent vitamin D deficiency is quite common in primary hyperparathyroidism. And indeed, epidemiological evidence suggests that these patients have worse disease, if you like, if they also have concurrent vitamin D deficiency. And whilst it's, of course, a disease of hypercalcemia, and there may be a concern that correcting vitamin D deficiency will exacerbate the hypercalcemia, but this is not the case. So finally, my take-home messages are that vitamin D deficiency and insufficiency is a global health issue, and I think it contributes significantly to poor bone health. I believe strongly that effective personal, individual and public health measures could significantly reduce metabolic bone disease and all the burden associated with it. The target for bone health is 75 nanomoles per litre, or 30 nanograms per mil. Most people perhaps will need supplements to achieve this. If supplements are required, this should be done ideally daily. 25-hydroxy-D is the appropriate test to assess vitamin D status. And don't forget that adequate dietary calcium daily is also essential for bone health. And I thank you very much for your attention.
Thank you, Helen, for that very clear and very useful presentation. We will go straight on to the questions. We got quite a few questions. I'll start with the first one. Can I ask why a laboratory would still use RIA given the new assays available while RIA produces very hazardous waste? I totally agree with your question. I believe the RIA is used mainly in the USA because of FDA approval. I think the RIA is, I may be outdated, but the RIA was the only FDA approved assay for P1NP at some stage. If that's still the case, that may be the reason. Is there a place in routine practice for these markers, CTX and P1NP? It's generally used by specialists. Yes, for osteoporosis, mainly specialists, but for Paget's disease, certainly P1NP or total alkaline phosphatase is adequate, but they are required for management. Since there is no clinical laboratory diagnosis of osteoporosis, can assay of serum albumin, calcium phosphate. So we measure calcium phosphate, etc., in patients with osteoporosis, together with PTH, vitamin D, really to look for secondary causes of osteoporosis, not for the diagnosis of osteoporosis, but to diagnose any causes for osteoporosis. Most patients with osteoporosis have postmenopausal or osteoporosis of old age. So laboratory tests are not needed for that, but to exclude secondary causes, yes. There was a question about Dexan. It's not quite clear to me. I'll move on to the question on PTH. Can PTH be used as a differentiating parameter between different hypercalcemia etiologies? That's for Hans.
Yes, and in fact, it is the crucial test that helps you differentiate between hyperparathyroid disorders and non-hyperparathyroid disorders. And if you have suppressed PTH, then you go on and do other tests looking, for example, for 125 vitamin D and other things. But PTH is your first line test. And which assay is the best suited for a better PTH exploration? Well, I have to say, despite having a third generation assay, they have been disappointing. It's not that you get better diagnostic accuracy and more sensitivity in detecting primary hyperparathyroidism. We use it because it gives you overall less interference for renal elevation, but the evidence is not strong.
Standardization of PTH, is it a realistic possibility, Hans?
Well, I think the advance of a mass spectrometric method allows you to say this is 1 to 84 and get better standards. So I hope that it's part of the way there. I still think the use of antibodies to enrich the PTH before you can measure it is a weakness there.
So the next question is for Helen. We heard about the absorption and the diseases related.
Yes, thank you. I see the question. certainly that is something that needs to be taken into account in choosing a supplementation regime. So if you have malabsorption, then you are going to need a higher dose supplement than a person who does not have malabsorption. So if you have celiac disease, for example, or some kind of chronic inflammatory bowel disease, then you're likely to need higher level of supplementation, but you should not undertake very high levels of supplementation without clinical supervision and an assessment of the effect that it's having on your 25D level. The no obvious adverse effect limit is, according to the National Academy of Medicine, around 4,000 units a day, whereas some other expert groups say that up to 10,000 units a day